Okay, we're going to continue on heart failure and cardiomyopathy. Okay, heart failure is the inability for the heart to fill or to eject blood to meet the tissue requirements. Okay, so that can have many, many different reasons for that. Okay, the symptoms usually will lead to left ventricular heart failure, which basically leads to dyspnea, fatigue, circulatory congestion, and hyperperfusion. Heart failure is actually the most common cause of RV failure, is left ventricular failure, and it's actually the most common DRG diagnosis. This is actually a census report showing you the actual deaths due from congestive heart failure in the United States from 1968 all the way to 2002. As you can see, there's been not much of a difference or change. With all the medical advancements we've had, patients are still dying at a higher rate due to congestive heart failure than ever before. Okay? So heart failure is a very, very big problem for us. It's going to continue doing that as well, because what's happening is this correlates with what? Age. The population is aging, so because of that, the numbers are increasing as well. If you were to actually mix this and do a dual study where you had age and related deaths to congestive heart failure, then you would see a little bit of flattening of the curve, but not by much. Yes, sir. The data supposedly for that it's been spurious. In other words, means that they don't know what exactly happened during that time. They try to figure out it was the new antihypertensives that all of a sudden kicked in. What we think most likely happened was there was a lot more research done in new antihypertensive therapy, and the medications were applied, and they thought they were going to have this under control. What it did basically just gave it time. Okay? It prolonged the survival rate on patients, and then the slope began to increase again as the pathology continued. Okay? So giving somebody an antihypertensive will just delay the time period between the episode of starting and failure point. So, okay? But the question is, why are they developing? Do people in third world countries develop congestive heart failure? And the answer is yes, they do. Okay? But at lower rates than us. Okay? They die of other things. And it's usually the answer to that. We are able to die from congestive heart failure because we have better health care. Okay? You're able to survive infectious diseases that would normally kill you if your heart was marginal. Things of, you got to die of something. Okay? And heart failure is just one of those things. Heart failure can be due to impaired myocardial contractility from ischemic heart disease being very high on our list in the Western societies. Cardiomyopathy can also be induced from many different causes, which could be viral, could be bacterial. Cardiac valve abnormalities can also lead to congestive heart failure. Systemic hypertension is by far a very high culprit for causing congestive heart failure. Diseases of the pericardium can also lead to this, as well as pulmonary hypertension can lead to right ventricular heart failure. The hallmarks of congestive heart failure is decreased cardiac output. It's associated for the left side with increased ventricular end diastolic pressure, okay? And leads to peripheral vasoconstriction and eventually to decreased perfusion to tissue, developing metabolic acidosis. Cardiac output is decreased almost invariably in all these cases. The ejection fraction is usually decreased with a normal heart rate increases a lot of times in these patients. Okay? So sometimes you'll see these patients with low cardiac outputs with very high elevated heart rates in their 75, 60, and then you got to worry about them. The normal volume should be around 60 cc's per beat, and these people can be as low as 15 to 20 cc's per beat. So that's a very significant fall. The end diastolic pressure invariably increases, not decreases, okay? Because what happens is the ventricle is losing its ability to contract. The volume increases inside those ventricles, and eventually that leads to an increase in pressure. If it's a slow congestive heart failure where the heart begins to dilate over time, the pressure is not until late, okay? Because the volume is tremendously increased inside the ventricle. But eventually it will catch up and will increase the diastolic pressure. The forms of ventricular dysfunction that you see, you can basically break it down into different types. It can be called systolic or diastolic dysfunction. Systolic dysfunction is usually from an afterload, workload is too high. It could be from a valvular dysfunction as well, such as aortic stenosis. So that's a systolic dysfunction. Okay, or patients that have severe hypertension, okay, may also develop into a systolic dysfunction. Okay, the diastolic dysfunction, on the other hand, is a disease process that's usually due to the inability for the ventricle to relax, and that's usually from lack of ATP. So you're looking at ischemia, okay, as being very high on that list, or patients that are prone to developing infarct. The ventricular dysfunctions can be acute in onset. In other words, you can have somebody who's young who develops an acute viral cardiomyopathy and develop significant problems, or it could be a late sign. Somebody's been having rheumatoid arthritis over time, and you're actually causing inflammatory changes inside the heart and causing it to fail eventually. So it can be chronic as well. Congestive heart failure could be left or right. Okay? Left ventricle failure is by far the most common, and the most common cause of right-sided failure is left-sided failure. You can have independent right heart failure, but that's more rare. We should call that usually cor pulmonale if it's initiated by the high elevated pulmonary artery pressures. In right heart failure, the lung is dry, but in left heart failure, invariably always the lung is wet and has an increased incidence of pulmonary edema. You can also have high output, which means that the cardiac output is actually very high in that situation, but it still doesn't meet the requirements. It could be from increased basal metabolic rate. So there's a patient who develops, let's say, malignant hyperthermia, okay, will actually have a high output congestive heart failure, okay, because they can't keep up with the delivery of oxygen, and that person will develop metabolic acidosis that will be very severe and still kill the patient. They all have in common increases in left ventricular and diastolic pressure. These are the different examples of systolic dysfunction. Okay, systolic dysfunction is the enlarged heart. It's in the blood. It's been gorged with blood still because it has an output failure. In diastolic dysfunction, the ventricle may actually be small. The reason it's small is because the ventricle is not able to dilate, but the pressures may be high. Okay, so that's usually diastolic dysfunction. Okay. Systolic heart failure is decreased ventricular systolic wall motion. These are the different etiologies. We have regional defects in ventricular contraction, such as an advanced coronary artery disease. You can also have a global ventricular dysfunction from dilated cardiomyopathy, chronic pressure overload, some aortic stenosis and chronic hypertension, chronic volume overload, such as AI or high output cardiac failure. Systolic heart failure is seen in middle-aged men, usually with advanced atherosclerotic coronary artery disease. And ventricular dysrhythmias are common with patients with development of this. And they usually will develop a left bundle branch block and are at high risk for sudden death. Systolic heart failure has decreased ejection fractions and increased diastolic volume of left ventricle. The measurements of left ventricular ejections via echo, which differentiates it between diastolic from systolic heart failure. This is an important differentiation that you should realize, okay? Because if it's systolic hypertension, it's a little bit more difficult to treat sometimes because it's an underlying outside cardiac problem. If you have a diastolic dysfunction, which is usually an indication of ischemia, if you reverse the ischemia, the diastolic dysfunction gets better. So when you go for open heart surgery and the patient is going to have a 4-vessel CABG, and you look at TEE, you can see the ventricle is small and it just doesn't relax. Okay? You put the new coronaries in, and all of a sudden the ventricle is now pumping properly. So sometimes it can be reversed by treatment. Okay. Here's what ends up happening with long-term hypertensive cardiomyopathy. You get left ventricular dysfunction. You get remodeling that takes place, which leads to low ejection fractions and eventually arrhythmias or pump failure, which leads to death. These are non-cardiac symptoms initially, such as hypertension, okay, but you do get remodeling of the heart. Now, what's really interesting is the drugs that we know that this remodeling occurs due to signals from receptors inside the heart, and beta blockers have been found to stop the remodeling from taking place. So it has to do with some form of sympathomimetic effect. So it's a G-coupled protein activation, which leads to a secondary messenger going into the ventricle to actually change its actual shape. So by giving these people beta blockers, you actually stop the remodeling effect and hopefully stop the development of low ejection fractions. That's why people are put on beta blockers nowadays in very high amounts. Diastolic dysfunction is characterized by abnormal ventricular relaxation, reduced ventricular compliance, and so you have a significantly reduced compliance. If you look at systolic heart failure, where you get a dilated heart, you actually have an increased compliance. Okay? The ventricle actually is getting too big. Versus in diastolic dysfunction, the compliance is decreased. Okay? So you have reduced compliance. Now, what also that means is that your preload curve is changed. Okay? If you were to do a pressure volume loop, okay, in patients with systolic dysfunction, you'll see that the preload curve gets flatter, okay, in the chronic stage, and then the pressure eventually the ventricle dilates and they're out here. But in diastolic heart failure, the actual preload curve shifts this way, and when it shifts upwards, it causes for a smaller, a little change in volume, you get a much higher change in pressure. That's why you'll see low volumes in these heart failures, in diastolic heart failure, but still very high pressures. Okay? Class 1 diastolic heart failure has a normal left valvular relaxation pattern with a normal left atrial pressure pattern. What's interesting about it is that when you get the diastolic heart failure, the atrium becomes increasingly more important in its delivery of volume into the ventricle. If you lose the atrial kick, in other words, you go from normal sinus rhythm to atrial fibrillation, these people can be really symptomatic very quickly. There's class 2, 3, and 4 abnormal LV relaxation as well as reduced left ventricular compliance results in an increase in left ventricular and diastolic pressure because it begins to alter the preload curve on this. Factors that predispose to decreased ventricular sensibility include myocardial edema, okay, fibrosis, hypertrophy, aging, and pressure overload. The most common cause of diastolic heart failure is ischemic heart disease because you're lacking in production of ATP, which then the muscle cannot relax properly. The other thing you also see it is in long-standing essential hypertension, but that tends to form a lot of times a systolic heart failure, but it's also a common cause also of diastolic heart failure. Okay? Progressive aortic stenosis may also lead to this as well. Obesity and diabetes also have very strong correlations with diastolic heart failure. Okay, and this is the differentiation when you're looking at these two. Okay, you're looking at diastolic heart failure is usually frequently in the elderly, versus systolic heart failure tends to occur in more younger people in the 50s and 70s. It's frequently seen more in male and with systolic heart failure than compared to women for diastolic. The left ventricular ejection fraction is actually maintained with diastolic heart failure initially. Okay, and systolic heart failure, on the other hand, because it starts to dilate and it starts to lose its contractility, you actually see a reduction in actual cardiac output. The diastolic heart failure leads to concentric left ventricular hypertrophy versus systolic heart failure leads to dilation. Okay, that's why we give beta blockers to systolic heart failure because it hopefully will stop that remodeling to take place. Okay, you do get a third heart sound with systolic heart failure. But you get a fourth heart sound with diastolic heart failure. I'm not going to ask you that because I can't hear a fourth heart sound. I have never had it, been able to hear it in 20 years of practice, so I can't hear the difference. So I don't think many cardiologists can either. Hypertension may also be much more frequent with diastolic heart failure comparison, and diabetes is more frequent as well with diastolic heart failure. Chronic versus acute. That's the next one. Chronic heart failure is present in patients with long-standing cardiac disease, okay, due to venous congestion and blood pressure is usually maintained. Acute heart failure is defined as changes in the signs and symptoms of heart failure requiring emergency therapy. You'll see a sudden decrease in cardiac output with systemic hypotension is usually a typical presenting sign. You don't get any signs of peripheral edema. Okay. 3 clinical entities worsening chronic heart failure. You can get new onset heart failure such as a cardiac valve rupture, large myocardial infarctions, or you may actually get terminal heart failure, which is refractory to therapy, of course. Manifestations of left ventricular failure is basically the pressure begins to back up into the lungs. So the lungs have reduced lung compliance. Okay? Make sure you get that. There's a reduction in lung compliance. There's an increased incidence of congestion of the bronchioles, so you can get increased resistance, okay? So increased work of breathing due to stiffness of the lungs and also due to the weight of the lungs. Okay? It's usually the earliest symptoms of congestive heart failure. Sometimes you'll hear a little bit of wheezing all of a sudden develop in a patient. And it's also quantitated by exercise tolerance. The patients that are developing these problems, as soon as they start exercising more, they become increasingly dyspneic and orthopneic. Okay? You'll see for physical signs, you get rails on auscultation. Third heart sound is the earliest indicator. That's always asked on the boards. to make sure that left ventricular heart failure is indicated by third heart sound. Okay, chest X-ray shows curly B lines. You see vascular congestion along the mediastinum, and then you'll see that the chest X-ray becomes increasingly more white because of the increased vascular tone, the vasculature inside the lung. In PND, you may also develop, which is paroxysmal nocturnal dyspnea. The patients will suddenly wake up in the middle of the night. It's because when the patient lays down, all the peripheral edema begins to come up their lungs and floods them out. So the patient will wake up because of the lack of oxygen being delivered to them. They also may develop acute cardiac pulmonary edema when you exceed pressures of greater than 30 millimeters of mercury. It's usually from ischemia that's developed acutely, and the mitral valve becomes incompetent, and you get large V waves. Manifestations of right heart failure, on the other hand, is that the patient is essentially the lungs are dry, so you don't develop a decreased compliance in the lung at all. The lung actually remains normal. Okay? The lung, when you listen to it, sounds normal. Okay? So it's independent right heart failure. All you'll see is a congestion of the liver and spleen. You also will see a very large JVD, just jugular venous pressure, okay, distension, and you may actually cause problems with organomegaly of the liver, and you'll start producing proteins. One of the important proteins that it stopped producing is the coagulation proteins, so these people will have elevated PTs. Okay? That's an indication to you that you have significant problems with the liver at that point. You will also develop significant amounts of peripheral edema. The organomegaly can actually be palpated, and you can actually get ascites as well. Prothrombin time is prolonged. The peripheral edema can be really pretty massive. You get pitting edema in these people, and differentiate causes by looking at Kuhl's-Morris sign, which I'm not going to talk about today. Low in high cardiac output failure, the normal cardiac index varies between 2.2 to 3.5 liters per minute. The most common cause of low output cardiac failure, of course, is atherosclerotic coronary heart disease. Cardiomyopathies of different types, which we'll talk about a little later on. Hypertension, valvular disease, and pericardial disease. The causes of high output failure include anemia, okay, pregnancy due to AV fistulas, which is the placenta, patients that have AV fistulas. And it could be something they don't know about. Maybe somebody has just come in for a central line placement for several months ago, and patient is now developing a high output cardiac output. And what you do is when you palpate the person's pulses, you can feel that it's very fast, and usually they have a very elevated heart rate. And when you're doing an exam, you listen over the carotids and you hear a whoosh, 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 whoosh. What you basically identify at that point is an AV fistula in the person's neck. Okay? That can actually happen from a central line placement. Okay? Somebody puts a central line through the carotid artery and through the internal jugular vein, and didn't realize it. And now the two artery and the vein is actually connected, and now develop an AV fistula. And that can lead to a very high output congestive heart failure. Okay? So think about that as well. Severe hyperthyroidism can also cause it. Anything that causes hypermetabolic syndromes where increases basal metabolic rate. Patients that have neuroleptic malignant syndrome or malignant hyperthermia will all lead to a high cardiac output failure. You may also have vitamin B12 deficiency, which causes beriberi disease, which can also cause a dilation in the heart and still leads to a high output cardiac failure, and things like Paget's disease as well. Adaptive physiologic mechanisms such as Frank-Starling relationship. Frank-Starling basically follows the same Starling curve, but once it doesn't follow the curve once it was above the point of maximal cardiac output. So then you're over the top of it, the heart begins to dilate, and as you give more volume to that person gets worse. So if you're looking at systolic hypertension, that person is more likely to dilate early. So those are the ones that put you at much higher risk of giving more volume to them, and they actually get worse. The diastolic heart failure patients will get slightly better with more volume, but you've got to be careful because their ventricle doesn't relax at all, and what you end up doing is if you give a lot of volume, you'll flood them. Okay? But sometimes you're sort of forced to get some volume forward because the ventricles actually stays empty. You got to watch their inotropic state. Some of these people will start to fail, and you actually may have to give supportive catecholamines to help the inotropic state. Afterload may be inappropriately high in many situations, and dropping the afterload can significantly improve forward cardiac output. So dobutamine is a great drug for these people. Okay? The reason the butamine is a great drug is because it increases contractility, and it drops your SVR in the process and drops some degree of preload. So all that's perfect for somebody in this kind of situation. Heart rate is, of course, can be good or bad depending on the situation you're in. If you have a very rapid heart rate, of course, but if you have no cardiac output, it might be stroke volume, that may be the only reason that you're having a cardiac output. So be careful about dropping heart rates down in an acute setting because you actually may put the person into a worse state. Okay? Myocardial hypertrophy and dilation are bad signs because at that point you've had delayed therapy. Sympathetic nervous system activity tends to be overactive, and the patient's heart rate is driven by that. So giving these people fentanyl and suppressing the sympathetic nervous system, you may actually have cardiovascular collapse occur on you. So be careful when you're doing this, when you're putting somebody like this to sleep. Be real ginger with your narcotics. Even though they say to you in the books that narcotics don't have any effects on blood pressure, that is true directly. It does not cause alpha vasodilation. It doesn't do any of that, okay? But it does suppress the sympathetic drive. Okay? And when it suppresses the sympathetic drive in this kind of person, you might lose out all your adaptive mechanisms. Okay? The Frank-Stardium relationship, which shows you here, has a congestive heart failure drops off. Digoxin can be used to improve the contractility for long term, or you may consider also dobutamine, which would be high on my list from these patients, to be using the right drug. Make sure that you do know all the different cardiac drugs that we've talked about before. That's expected anyway, so you should know that by stuff by now. Inotropic state, myocardial contractility is significantly impaired in this, and the velocity of contraction can be significantly impaired. So giving a inotrope in this kind of situation can significantly improve that. Okay? The decreases in inotropic state is what leads to congestive heart failure. And volatile anesthetics actually suppress the contractility more. Halthane by far being the much more of the potent of these. Afterload is inappropriately high, so tension in the ventricle must develop to open the aortic-pulmonary valve. In heart failure, this increased afterload is inappropriate, and activation of sympathetic promotes arterial constriction. So what you want to do is give something to reduce the afterload but not drop the blood pressure off completely. So you have to be careful doing it. Okay? The downside to doing this is that you will also concomitantly decrease your preload in some situations. If you have somebody already in failure and they're over the top of the preload curve, that actually works kind of well. Okay? But if you have somebody who has diastolic dysfunction and has a fairly small, empty ventricle, and you drop their preload even more, they can get in a worse situation. So you got to know which one you're dealing with. Okay? That's why slipping in a TEE on these people can be really invariably very helpful. The PA catheter has a very difficult time differentiating diastolic heart failure from systolic heart failure, because all it says to you is it has an elevated PA occlusion pressure. That's all it tells you. It doesn't tell you what's the etiology. It doesn't tell you if it's a stiff left ventricle or a dilated left ventricle. So sometimes it can be difficult to differentiate, and that's why TE can make a big difference. Remember, cardiac output equation, heart rate times stroke volume. In heart failure, heart rate tends to be increased to try to maintain for drops in stroke volume. So make sure that you don't kill the person by dropping their heart rate too much in that situation. Okay? It's sometimes an appropriate thing. If you see that the person's above 120 heart rate, then usually the 120 heart rate's not really helping you too much because at that point you get diastolic limitation in your time limit to fill the ventricle. But by giving that person just a little bit of esmol to slow them down to say 100 heart rate can make the person improve significantly. Okay, so and then the heart hopefully will fill more properly and eject. Okay, now if you have systolic dilation and you drop the heart rate down even more, then the heart will have more time to fill, and then it puts it over the top and more into the Starling's curve on the failure mode, and that's not what would be good in that situation. So make sure which one you have. Okay, the other way, if you don't have ability to put a TE, just get a chest X-ray. If a chest X-ray shows that the ventricle is grossly enlarged, guess what? You're dealing with systolic dilated heart. Okay? If the ventricle looks normal, okay, but you still have heart failure symptoms, then you're dealing mostly with diastolic heart failure, and you can basically at that point give that person a little bit of beta blocker and they'll do fine. If they have systolic dilated heart, then stay away from the beta blocker. Give that person a little bit of preload reducer, nitroglycerin, a little Lasix, get the fluids off that patient. Maybe that person will improve after that. Okay? Remember the primary treatment. Most people come in this kind of situation because they're developing ischemia. So MONA is pretty high on your list. Okay, morphine, oxygen, nitrates, okay, and what? Aspirin. Okay, so don't forget all those. Okay, morphine is a preload reducer that helps, and the other one that helps you is the nitrates, which are preload reducers as well. So that sometimes will get you out of trouble in these kind of situations. If you have anybody with congestive heart failure, unless it's a total emergency, the case is contraindicated, you're done. Send the patient back to the ICU. Do not do the case, period. But if you're forced to, then you've got to treat it quickly. And you've got to know how to do that very rapidly. Okay? My point at that point is put everything in that you need up front. Okay? TEE, PA catheter, A-line, load the patient up with monitors. The more the better. Because guess what? When you have to make a hard decision, the more information you get, the better the decision is going to be. Okay? So don't hesitate about putting in things. Okay? Don't do just do the A-line. Let's see how they do. And then you go into the room and everything falls apart. Okay, let's put the PA catheter now. Oh, okay, it still doesn't work. I don't know if we have systolic or diastolic. Okay, let's put the TEE in. I mean, come on. That's not the way you do things. Be aggressive up front, get it in, and then figure out what you got. Okay? Don't play games. Okay? Because the whole time you're playing and you're delaying, the surgeon's having to wait, okay? And the patient's getting worse. So be aggressive, get your stuff in early. Hypertrophy is an early form of compensation from pressure overload. We've talked about that in the past. And things like mitral stenosis, aortic stenosis, hypertension, pulmonary hypertension will lead to different ventricles. And then cardiac dilation occurs, unfortunately, after hypertension occurs, hypertrophy occurs, unless the person has extreme volume overload conditions right up front. So things like MR, AI are things that you'd see. The humoral-mediated responses that can occur from this is that the heart will actually begin to dilate, and when the ventricle or the atrium begins to dilate, it usually will release increasing amounts of atrial natriuretic factor to try to diurese the patient. Okay? But what happens in these diseases is that the ANF literally gets burned out. It's no longer being released. So even though the ventricle is dilating, or the atrium is dilating, there's no more ANF release. Okay? So you don't get any more diuresing effect. And that can be significantly detrimental to the patient. They'll actually begin to hold water instead of actually getting rid of it. Normally, ANF will lead to a increases in GFR to natriuresis and diuresis, okay? But it also suppresses aldosterone and antidiuretic hormone. Okay? But without this, you can see what would be the reverse effect. You would see increased volume in this patient. The humoral-mediated responses are due to decreased renal perfusion. Will also lead to the release of increasing levels of renin, which, of course, remember we're talking about this, leads to angiotensin II levels, which causes more systolic hypertension to develop. It also, angiotensin II, goes to the adrenal cortex and asks to release more aldosterone, which then retains even more water. Okay, so basically you're putting this person in a worsening failure, okay, and that's what they don't need at that point. When I was a young medical student, I guess I was 23, 24 at that time, got invited over to the VA hospital, and they had found this new magical drug, or they were just getting this new magical drug that the FDA had had for about 5 years, called Lasix. So we went over there, and we had this patient that I'd never seen edema like that in my life, and thank goodness I haven't seen it that much after that. The guy must have had about 60 kilos extra of fluid on board. Okay? He had been in congestive heart failure, in and out of it, and survived it for almost 4 years. So he had pretty impressive legs. His legs were about as big as tree trunks. So they put an IV in this guy, and they gave him 20 milligrams of IV Lasix, and a person who's never been exposed to Lasix before. And all of a sudden, the guy started urinating, and he started asking, I need more. I need another urinal. We were going, what? He went from 1 liter, 2 liters, 3 liters, 4 liters, 5 liters. And we're looking at each other like, wait a minute, there's only 5 liters of blood in the patient. Where the heck's all this stuff coming from? And he literally put out 22 liters in about an hour and a half. Okay, it was really impressive. Okay, we were all like, uh-oh, we got a big problem in our hands. We thought this guy's going to die. He actually felt really good. It's like, I can breathe again. It was rather impressive. But we learned that day too. You only give somebody who's never been exposed to Lasix, you give a smaller dose. You don't give the full 20 milligram dose. 5 milligrams usually works just fine. So make sure you're careful when you're giving it to first-time dosing to somebody. So it shows you these systems are completely shut down. They're completely reversed of what they should be in this patient. Okay? And what we've done now with congestive heart failure patients is we're pretty aggressive about getting volume out. We're actually a little bit too aggressive, okay, in the sense that we dehydrate them so much so that they're like what I call popcorn. Okay? The reason popcorn pops is because the little bit of water that was inside of it, when you heat it up, it expands and blows up the popcorn. Okay? So these people are really, really dry, to say the least. Okay? And when you put them to sleep, they can fall apart on you really quick because you preload reduce them when they're already severely dehydrated. So cardiologists are always prone to drive the person to be in a really dry state because it keeps them out of the hospital. The nephrologists, on the other hand, are really not happy about that because they tend to shut down the kidney in the process. So it's got to be a little bit of balance somewhere. The diagnosis of heart failure, of course, is physical exam, history, interpretation of diagnostic tests. You can do serum BNPs. Those are being used as indicators to somebody still remaining in heart failure. Those kind of studies, the only thing, the shortfall in them is that in chronic congestive heart failure, the BNP levels, which is very similar to the ANF levels, are a little bit disturbed. So I don't know. I sometimes read those studies and go like, is that really the best marker we can have? Anyways, things that do affect us are age, sex, and renal clearance, obesity, patient's prior history of PEs, atrial fibrillation, and other cardiac dysrhythmias can also make this. This is a typical abnormal chest X-ray with a large dilated heart. That's a cardiomegaly. That's a person with systolic muscle dysfunction. The New York heart classification was used back, I think, in the 1960s or 1950s was the first classified. It's really try to, what's that? No, okay. I heard things. Okay. Anyways, New York heart classification basically talks about giving symptoms to a patient with congestive heart failure and seeing how severe those symptoms are, and then basically they would follow it up to see what kind of outcomes you had. Okay. The less the class number, the better your outcome is. Okay, and also the less severity of the disease process. In class 1, ordinary physical activity does not cause symptoms, even though you may have a reduced EF, let's say, of 30%. So those people are considered class 1. They live pretty long. They do seem to do fine. Class 2, on the other hand, occurs with ordinary exertion. Those still have a very slow risk in having anesthesia. But then the class 3 and 4 is the one you have to worry about. Class 3s are the ones that symptoms occur with less than ordinary exertion. And then class 4 are the most dangerous because those are symptoms at rest. Okay? Those people are already basically in chronic long-term failure. So that's ones you have to really be careful with and you have to put them to sleep. The progression of disease in stage A, patients at high risk for heart failure but without structural heart disease or symptoms. You have stage B where you have patients with structural heart disease but without symptoms. And then stage C is patients with structural heart disease with previous or current symptoms. And stage D is refractory heart failure requiring specialized intervention. Treatment of heart failure is to reverse any reversible causes, anemia for high output failure, hypertension, of course, valvular heart disease, and make sure that if you sometimes may induce heart failure by beta blockades, sometimes stopping beta blockers may be an appropriate thing to do. Pharmacological treatment includes digitalis, preload reducers such as diuretics, and afterload reducers may also be effective. This is what the different drugs will do. Beta blockers will slow down the heart. Dig basically is an inotrope and also an AV blocker, so it prevents tachydysrhythmia such as atrial fibrillation, hopefully to take place. You can do cardiac resynchronization therapy, which is you can put a dual pacer in to help with dual pacing of the heart. Okay, so that means both ventricle and left and right ventricle are firing independently of each other, and then you synchronize it to give you a better EF. What happens when you put a pacemaker in is that the right ventricle fires first, which is not usually what happens normally. Usually the other way around. The left ventricle fires first. When the right ventricle fires in this situation, it actually will take up space because it causes the septal wall to shift inwards towards the left, takes up some volume in the left ventricle, and then you lose the ability to actually eject. So having the dual pacemakers, it gives you that ability to resynchronize the heart and to get the left ventricle to fire first. and it gives you a little more volume in the left ventricle. Okay? You can have ACE inhibitors that basically block the effects of renin. Diuretics, of course, to let more excess fluid to go out. Okay? And then you have your ACE blockers, which are more potent, and then ACE inhibitors. Those are actually inhibit ACE itself. So, sorry, not ACE, but what's it called? Angiotensin blockers. So it prevents angiotensin from working as well. You have also peripheral vasodilators directly that you can use. So there's many different drugs that are available for you. And this is what you can actually look at when you look at stage A. You're looking at risk factors, reduction, family, education, okay? Treat hypertension, okay? When you have stage 2, you're looking at patients that should be put on ACE inhibitors. If you're in stage 3, you need to add all the following, plus dietary sodium restriction. May consider cardiac desynchronization and revascularization. Consider a multi-team approach, and then when you get to stage D, then you need to consider a hospice in that point, okay? Because at that point you're not going to get any better. So this is a way of staging somebody and seeing how much therapy you have to give them, okay? What's the best kinds of therapy. These are the kind of trials that are being done now to hopefully make some effects on that initial line that I showed you before where we're not getting any improvement. Because what's happening is you have many different cardiologists. Everybody's getting trained just a little bit differently. So everybody's following different protocols. And that's just not working. So what we're going to try to do instead is try to give a universal, hopefully one good treatment and make it, see if it works best. But you know, it's just like if you want to have, well, we'll see how it goes. I won't put my political statement in this. Management of systolic heart failure, inhibitors of renin-angiotensin systems such as ACE inhibitors or angiotensin II receptor blockers are very powerful agents, may be also very useful in these patients. It also helps prevent remodeling by decreasing the actual systolic hypertension. Aldosterone antagonists such as spironolactone have also been used. Beta blockers improve the ejection fraction and actually decrease ventricular remodeling as well. And they also have been found to reduce morbidity in long-term management of patients with systolic heart failure. Diuretics have also been helpful because these are preload, overloaded patients, so they tend to do better as well. Management of diastolic heart failure, on the other hand, is mostly empirical. Its best treatment is prevention. In other words, make sure that you prevent the ischemic events from taking place. No drugs that selectively improves diastolic distensibility. That's a bad thing. That means it's harder to treat. Okay? Some people are actually using now calcium channel blockers to try to let the ventricle relax a little more. Okay? Has it really worked? The answer is so far the studies don't show that much of an improvement, but some people are still trying something to cause the muscle to relax. The best treatment is revascularization, really. Okay? If you revascularize the heart doesn't get depleted of ATP and is able to relax once again. So management strategies for diastolic is treat your coronary artery disease, treat hypertension, control weight gain, and to treat diabetes. Okay? There's actually been allowed adequate filling time of the left ventricle by decreasing heart rate. This is going to be done by beta blockers, okay, calcium channel blockers as well has also been helpful. They also help inhibit some of the calcium release, which decreases your contractility, but also gives it more time for it to relax the heart. Controlled volume overload can also be done, but this is not usually a volume overload problem so much, so not like a systolic heart failure. Restore and maintain sinus rhythm is critical. Patients that have diastolic dysfunction because the ventricle is so much more rigid really require an atrial kick for adequate function. Current precipitating factors are, if you have aortic valve disease, you replace it. Coronary revascularization is the right thing to do. If you do develop congestive heart failure, what do you give? Digital should be pretty high on your list. It's an orally effective positive inotrope. It increases myocardial contractility, decreases cardiac size, and increases cardiac output. Digitalis, unfortunately, has a very high predisposition to toxicity, especially with patients that have symptoms of hypokalemia, hypercalcemia, hypomagnesemia. Okay? Signs and toxicity usually due to anorexia, nausea, and my favorite one to ask is, do you see a yellow halo? And the person says yes, and we'll say you got dig toxic patient. Cardiac toxicity may actually cause problems with dysrhythmias. You may actually induce a complete AV block, and you may also induce bigeminy. So if somebody is on DIG and all of a sudden they start developing bigeminy, you might be in the toxic range. Okay? Treatment is correcting the predisposing factors. You get a much higher incidence of this in renal failure patients to develop DIG toxicity. So some drugs that you may actually reverse the effects are lidocaine. If you're getting bigeminy, you may actually think about getting phenytoin and atropine if you're getting complete AV block. Okay? Pacemaker may actually be needed if you get a complete heart block. Cancel elective surgery if you have DIG toxicity. If you are going to have to go for emergency surgery, don't give more sympathomimetics, such as ketamine. It's going to make it worse. Hyperventilation may also make the situation worse as well, because you're basically inducing a hypokalemic event, and that causes the DIG toxicity to actually get worse, not better. Okay? Treatment is reverse the hypokalemia. Treat the ventricular irritability with lidocaine. If you have supraventricular dysrhythmias, consider using phenytoin. If you get bradycardic, atropine followed by temporary pacemaker. And if you really aren't in severe straits, consider giving digitalis antibodies. The hospital pharmacist usually won't be very happy with you because it's such expensive therapy. Treatment of acute heart failure can include also diuretics, vasodilators, oxygen, morphine, okay, beta agonists, inotropic support such as catecholamine, and my favorite drug in case you're getting into big trouble is phosphodiesterase inhibitors. The reason that congestive heart failure patients develop refractoriness is because they get downregulation of the receptors. So you may actually consider giving these people like drugs like epinephrine or dopamine, and they don't seem to work. Okay? It could be also that the patient is in metabolic acidotic state, and you may consider giving them bicarb. But if after you give them bicarb, you don't see any improvement in cardiac output because it seems like the receptors aren't functional, it could be that the actual beta receptors are downregulated in the heart, and now nothing is functioning. Okay? So what you do is you bypass that using what's called phosphodiesterase inhibitors. Phosphodiesterase inhibitors work by actually penetrating into the cell and actually binding to cyclic AMP is the secondary messenger, and cyclic AMP is broken down by phosphodiesterase, okay, to an inactive form. So by giving a phosphodiesterase inhibitor, you block that out, and cyclic AMP levels increase, and contractility increases as a consequence. So I've seen that save a lot of people's lives, especially in patients that are in chronic congestive heart failure. The exogenous management to BNP, such as Natricor, promotes arterial, venous, and coronary vasodilation and induces diuresis. So that's another thing that's very helpful, because a lot of BNP is basically not in adequate levels in these patients, and that could be life-saving as well. Nitric oxide synthase inhibitors are things that are coming down the pike. Okay? Nitric oxide is a negative inotrope and has profound vasodilator action. Okay? And they're actually now considering giving these people inhibitors to shut that down. The new things that are coming down, actually, and Dick Cheney just had this put in him, is the left ventricular assist device. Okay? So he had an implanted ventricular assist device and went home with it, which is pretty impressive. Okay? And so that's an end stage possible, or a transition for transplantation. You may also consider emergency cardiac surgery, but of course these people have a much higher risk of not doing well intraoperatively. Okay? So this is what an LVAD looks like. Okay? You can see the ventricular assist device. It comes out, and then it actually helps with cardiac output coming out of the left ventricle. Okay? You can have a BIVAD, which means that you can have both the right and left ventricle assist devices put in. You can also have coronary interventions, coronary artery bypass, valve replacements. Sometimes they will consider doing ventricular aneurysectomies, which means they'll have ventricular aneurysm and then they'll cut that section out and then they'll repair it. There's been a very high risk of developing significant post-operative arrhythmias and deaths from those complications, or heart transplantation. Okay, it's pretty high on people's lists in these kind of situations as well. Cardiac resynchronization therapy, I already talked to you about, so some biventricular pacing, which I just talked to you about. Prognosis for patients with congestive heart failure is poor. Okay? You're looking at mortality rate for 4 years is 40%. Eventually they develop renal dysfunction with increased levels of BUN and creatinine, with significant hyponatremia and hypokalemia. They get severely depressed EFs, high levels of BNP, limited exercise tolerance, and they have PVCs. Surgery in the presence is basically a bad idea. Okay, not good. No matter which way you do it, it's going to be a bad idea, bad outcomes. If you want to do a regional anesthetic, you'll be fine during the operating room because you vasodilate, but because you're vasodilating, you're going to dump a lot of fluids in the patient, and then afterwards, that's when the patient gets into failure. So you either pave somewhere along the way. So most of the time, if I have somebody in acute congestive heart failure, I'll intubate them, put them under positive pressure ventilation, make sure the patient's oxygenating properly, and they seem to do better that way. At least I think they do. So I just put them under general. And I keep them that way until the person is doing fine. I limit my fluids. Most people that actually, on congestive heart failure, when you give them positive pressure, they actually get better. Okay? They get better for two reasons. One is you're decreasing the preload return, okay, because most failures are due to systolic heart failure. And the second reason is that you're actually compressing on the ventricle and you put it in a better portion of the starting curve and the heart actually ejects better. The cardiomyopathies is where we're going to stop here, and then we'll continue going on to the next section. So we got 10 minutes and we'll start back up.